is basically at University of Michigan, is basically our psychiatry team that consults on medical cases when they're medically admitted. So we're kind of coming from all angles of the hospital when it comes to psychiatry. Sorry, something happened with my screen, so I'm trying to.
So I can speak a bit on just objectives of today, because our kind of experience is specific to the hospital, and we do so much crisis management. We kind of came up with some objectives based on that experience and kind of research that we've done. In regards to intervening when youth are in crises. From a kind of psychiatric perspective. And so our hopes for today is that you walk away with an understanding of the different types of mental health crises that youth can experience. And I say youth, but we know that these things impact the entire family unit, and I want to acknowledge that. We also want to talk through suicidal ideation and self-injury evaluation, as well as interventions, and then share with you, supportive resources. A lot of these will be specific to Washtenaw County, but with the pandemic and a lot of these supports operating, for the most part, kind of virtually, it has kind of expanded to other counties in terms of accessing, resources. Anything that you'd like to add, Emily?
No, I think you said it pretty well. Yep. So I think, yeah. And if any questions come up during the presentation, I encourage people to just speak out or put it in the chat. I don't know if Michelle could, cue us in if there is something in the chat that needs to be addressed so we don't skip over it. So I just like to throw that out there because we would like this presentation to be ignite some conversations around, community and family dynamics, as well as, any kind of situations that come across when it comes to child and adolescent crises and how we can better manage them or initiate education around that, even if you're not in like the social work department or even at the hospital or even working in mental health at all. That's kind of what we're hoping for. And so we just want to make sure that we're coming across and making sure that we have time to have everybody kind of get involved in those conversations. And at the end, we will have a little bit of some time to go through some case studies and some breakout groups so you guys can practice hopefully what we've taught you a little bit about. So I don't know, do I have access to go to the next slide? I think I don't. Okay, so I'll just say slide then. So thinking about types of mental health crises, I think it's important to first identify what we're looking at in general. And of course, there's a lot of, these are kind of more umbrella terms. So I think there's a lot more that goes into just kind of identifying, like, say, something like anxiety, because anxiety can look like a lot of different things. But, I think it's important also that we do recognize that a lot of these mental disorders are usually emergent early life, and about 50% of cases have their onset by age 14, and 75% begin by age 24. And oftentimes, in the community, whether it's school or pediatricians or even, parents and family, sometimes we can identify some of these behaviors or symptoms of mental health, but they may not look as clear as they are, right? So in a small child, like anxiety could just be them complaining of a stomachache every day with no medical findings. And so, but we're looking at depression, anxiety, psychosis, eating disorders, autism, and other behavioral dysregulations that can come from, patients that have cognitive delays, and then substance use disorders. And as well as we may know, some of these can be silent and there could be no warning signals, and sometimes there's overt signals that could be people can pick up on to try to initiate help. Yeah.
So just something to keep in mind, especially as we talk about teenagers, is that adolescence is a really dynamic time within the family life cycle. They're discovering the power of language, peer relationships. They're wanting increased independence, wanting to spend most of their time with peers, experimenting, oftentimes kind of exploring sexuality, developing, identity, essentially. And this can make them more kind of vulnerable to taking risks, struggling with reasoning and judgment, being more impulsive, which can lead to kind of poor reasoning and judgment. Looking for ways to have fun and not necessarily maybe thinking of consequences. And it can be really difficult for parents, but professionals too, to kind of discern what's normative and what's maybe kind of abnormal. Just something to kind of keep in the back of your mind while you're assessing for these things. And we know as well that developmental disorders can play a role in mood disorders, kind of what that looks like, and can impact what treatment would be recommended. And so neurological testing, it's not something that we do here on the hospital side, but something that can add a high level of value in terms of diagnostic clarification and connecting families to the appropriate supports that they need. And then two, we know that exposure to substances in utero can have a significant impact on development, social functioning, and behavior. And it can oftentimes be a missing piece to treatment. And so you're not getting kind of the full picture if you don't have, neurological testing in those scenarios, and it's not something you're considering. And then, we could have a whole other presentation on trauma, but we're going to keep it brief just, for the sake of time. So, every child and adolescent experiences some level of stress in their life, both, emotionally and physically. And their reactions can look a lot different, especially kind of depending on the event. Their reactions might be brief, and they might recover without kind of further problems. A child really is going to be at risk of developing something like PTSD. Kind of given the seriousness of the trauma, whether the trauma was repeated or not, and the child's proximity to the trauma and their relationship with the perpetrator. I tell families it's really hard to heal and move forward if you're still exposed to the environment in which trauma occurred, or you're still in the relationship with the perpetrator, and things are kind of ongoing. And so if it kind of exceeds, an acute, like, single event, that's something that we would consider, terming complex trauma. And that can include emotional abuse, neglect, sexual abuse, physical abuse, bullying, witnessing domestic violence, ethnic cleansing, natural disasters, war, that all interferes with development, and often, the relationship within the caregiving system. And we know that trauma does put youth at risk for psychiatric disorders, substance use, medical conditions, and just, problems with kind of social functioning across all domains. We know that children who experience repeated trauma, they might develop emotional numbing to deaden or block in the pain. They might avoid situations that remind them of the traumatic event. They might become less emotionally responsive, more restricted in their affect, more depressed, withdrawn, more detached from their feelings. It really can present a lot of different ways. And everyone's reaction is different. Responses can include being anxious, sad, confused, angry, having difficulty concentrating, difficulty sleeping, poor appetite, being very preoccupied with the traumatic event itself. And I just want to kind of normalize that for anyone that's gone through something traumatic. These responses are, these responses make sense, and they typically lessen with time, and it's when they're not lessening with time and they cause significant functional impairment when something like a PTSD or trauma and stressor related disorder diagnoses would be given. Otherwise, it's kind of seen in the lens of like an adjustment disorder. And again, we could have a whole nother presentation on this. This is just a brief overview because we do oftentimes have kids present to us following, an acute traumatic event, or they're in these kind of pressure cooker environments where, something might kind of tip things over the edge and they need immediate mental health kind of intervention and support.
So I don't know how we could have a current presentation without addressing the pandemic. There's a little research on kind of what the long-term effects are going to be on not only adults, but more, what this is caused for the children and adolescents with the disruptions that they've had to experience. We do believe that with, some of the research that has been done, that it will affect the children, especially those amongst like certain like children ages and adolescents going because of the school disruptions, that it's probably going to have more consequences than adults that have gone through this pandemic. But it is important to recognize that, in March of 2020, there was more presentations to any emergency departments than ever before. And being one that come from an emergency department and has seen things for the last 10 years before I came to this unit, it was increasing over time before the pandemic, but then after that, it kind of exploded. And so you're looking at, from some studies will say emergency departments visits increased by 24% for children's ages 5 and 11, and 31 for those ages 12 to 17. Now, of course, these emergency rooms visits could be decreased if there was more, widespread outpatient care. But there was not even some of these resources before the pandemic. And then after the pandemic hit, what we're seeing is things dissipated. Like programs that we failed to refer to before either are no longer running because of their own staffing issues, or the wait lists are, quite frankly, so long that you can't even, you're calling a therapist and they're saying 9 months, or you're trying to get into a partial program, like a step down from the hospital, to try to take that slower transition, which some patients require when you're coming out of an inpatient hospitalization, and they're saying, okay, it's 3 weeks before they can get in there. So that step down does not exist anymore. And so this is leaving families before they even transition outpatient, they end up in the ER before they even actually happen, any kind of outpatient care happens. So that's, you're kind of looking at a lot of cases where the hospitalization is the family's first experience with mental health. Then they transition out of the hospital. The wait lists are so long that they're not, provided with any care, and they're already back in the hospital with another crisis before any care could be initiated. So this has left a strain not only with the health system, like from a hospital perspective, but the resources and then the distress with families, especially if it's their first experience with mental health. It can be very discouraging. So, it is critical to think about like strategies for mental health in the future. And some will say that, preparing children and adolescents, whether from school or personal peer support or family, could be of assistance, because if the more they understand prior to going into these events, the better off they're going to be able to manage them. And then that could be like thinking about considering how you can use simple terminology with children and adolescents to make sure they understand mental health, or even what a pandemic is, or we use it by using fact-based information. Some good tools for this is to use like videos and presentations that are tailored for children. UNICEF has really good programs like that could be distributed amongst families, or if you're a provider, let families know, like if your children are not understanding this, maybe use some of these tools or resources that are out there that are available now, since we've covered a couple years into the pandemic, to help explain it. And then again, using what we have in the community to assist with maybe learning basic coping skills to assist with decreasing stress and anxiety. Slide. I don't think I have the ability to change the slide. Okay, sorry. So if we thought, if we think about some of these things and try to put these resources in effect early on, it could decrease, fear of infection, pandemic related uncertainty, running out of supplies, helplessness, sadness, frustration, anxiety, all those things that kind of go into what's probably going through a young child's mind when they're kind of experiencing something like a pandemic. And of course, we could even add on all those uncertainties about school. When do I go back to school? When can I see my friends again? We're kind of out of that situation right now, I'd say lightly. But looking back in early 2020, all those what ifs caused so much more distress. So from an inpatient unit, I can speak to that. We would often see patients that were doing very well academically and socially, and then you take all that away, well, that provided them with a mental health crisis, right? Everything they're used to is now changed, and now they're failing because they're not used to Zoom, or they're not used to being secluded, or even what about all the children that may have received so many resources and services at school, and those have kind of dissipated for the time being, and how much did that cause, and even in fluctuation with maybe ER visits, but how much did that cause that patient to not have those resources? So how, and then their parents are too busy to assist, and how is that, what does that look like? It can look like a lot of different things, but I think it's definitely something to consider. So I when I was doing some research for the pandemic, I didn't come across too much, but I did come across understanding that there was some acts that were put in place. One, considering the American Rescue Act, was passed in March 2021. And this, was able to allow, $170 billion for school funding. And some of them were using this as, try to hire mental health workers and other people in the school to assist with managing the pandemic, whether it's, from a virtual view or in person. But what they didn't really take in consideration is, one, the shortage of the workforce in general, and then relying on temporary funding to hire permanent staff isn't really financially stable for all communities, especially lower income communities. So one, where do you find the work staff to do it? And how do you keep that funding going once it runs out to keep those positions, staffed? Therefore, they find that maybe be beneficial to start training more people in the community to help with these situations, whether it's teachers or school personnel, or basic, or even just family members, basic social and emotional skills, having them be better educated on grief and trauma and what that can look like in a child, and how to identify behaviors in the classroom when it comes to symptoms from mental health or even other psychological issues, to include like substance abuse. So if we put the education out there and learn some of these basic skills, then the kids could be picking up on this and utilizing them in their everyday life until they're able to get in with a mental health professional, which is what we know right now is it's really hard to get in anywhere. So we need some help in managing this, because it's just going to continue to escalate into more ER visits and hospitalizations, maybe that could be better managed at a lower acuity setting. So maybe somebody that we might not hospitalize in the past are now getting hospitalized just because there is no resources to handle the situation. And then maybe the parents are not, they don't have the education or the experience in mental health to navigate these systems. So it gets very complicated. So just wanted to we just wanted to kind of put up kind of a bit of a graph just to kind of understand the psychological factors when we're looking at large, disasters or pandemic situations. And so if you kind of just look over it, you can see how much it, at first it doesn't look like so much impact is happening, but then as we come over the last 2 years, things have definitely escalated when it comes to mental health, and how we're trying to manage it, being so short-staffed with resources and workforce, and what that's going to put our trajectory on in the future, because it seems like this is only going to escalate probably more before I think it kind of levels off, in my opinion. And then some of the studies that we show or kind of reviewed.
Yeah, and just to add, we don't know the ramifications, yeah, we can anecdotally kind of speak to what things are like at the hospital. I think the New York Times recently published a couple articles that are interesting. I would encourage, everyone, if they have an interest in this topic, to take a look about just like the state of ER visits due to psychiatric crises with youth across the nation, as well as wait times. Some families are waiting 3 to 4 days for a bed. There's such a shortage, and we just don't have the resources to meet the need and the demand. And if we're doing okay on time, we wanted to give space. We were initially thinking breakout rooms, but I'm wondering if this could maybe be like a broader kind of group discussion. Just thinking about ways in which COVID has, changed your life, and kind of what your observations are in terms of how the pandemic is impacting, the children and adolescents that you may work with or parent yourselves. So perhaps, you can just unmute yourself if you wanted to share your observations or reflect.
I could speak for a rural community in the Lenawee County area, where the biggest issue right now is just finding staff. We have so many people who they have just disappeared, and we can't find case managers for our foster care program. We can't find therapists for our counseling program. We can't find therapists, counselors to work with our substance abuse program. And it's become such an issue in southeastern Michigan that people are extremely concerned about it. And the waiting lists, they're interminable. What do? And you try to find, even if I work with kids in foster care, we can't find new foster beds, foster parents. You can't recruit people to do that right now. So foster parents are doubling up. They're beyond what the capacity. Getting the children who are in need of, we don't have any direct hospitalization here. We have to go out of the county for it, for any mental health needs for children. But even then, what we find is we take them to the emergency room, and they literally are sitting 3, 4, 5 days in an emergency room waiting for placement. And it can be 2, 3, 4 hours away from their family that lives here. So those are some of the things that we're experiencing right now, especially since COVID started.
Well, I'll support what Patricia was just talking about too. And she and I talked about in other luncheon lectures afterwards about the difficulty in ensuring that children who have been sexually abused are getting the support that they need as well. That's been a whole nother book that we haven't even opened yet, right? And then, so in our workplace, we too have experienced the whole shift in having the capacity to serve, even on the preventative level. And then also I was thinking personally, my daughter has now had 3 different teachers this year already. How are the kids in that classroom feeling emotionally? I know the school has done the best they can, right? They're trying really hard to ensure that those kiddos have what they need. She's in 3rd grade, and it's emotionally hard for all of them. And so that's been a real huge impact, even in our own household where we have resources, but there's 20 other kids in that classroom who may or may not.
Yeah, and we know those changes and transitions, they impact a child's sense of safety and security. yeah, we just don't know that the full ramifications, but we, can speak to the huge influx in terms of hospital services being utilized and in wait times. And families, they finally get up to maybe the inpatient unit, but then they have no outpatient provider to be connected to. And how do we expect them to continue to prioritize safety and wellness when they don't have that professional support to continue the work long term? Before we move on, just want to give space for anyone else to share if you feel inclined.
Yeah, I wanted to comment really quickly. I've noticed I was working at Ipsy Health Center in primary care, and absolutely, one of the biggest things that we noticed is folks, children, youth that have mental health issues before the pandemic, those get definitely worsened and lacking of resources. And those are the things that we first think about. But I also noticed kiddos that have special needs, those issues were really difficult. And I agree with Michelle, what you said, that the schools did the best that they could. I think education, folks need to get a raise, and I respect them tremendously. At the same time, the kids that have special needs, they had such a hard time, and their parents really had a hard time getting virtual services for their special needs. And I really felt for them, because I did understand that they needed to be protected. So it did need to remain virtual, but some of those services, it just wasn't the same virtually. And most things aren't the same, and it was just not as productive as it could be. But especially the kids that needed the special education services, I think they just fell behind even more. And so I think the parents were just so defeated and felt really discouraged. And so I really felt like that is a population that oftentimes are overlooked. And I felt just so bad. And again, the school was doing the best that they could, and also partnering with the parents at the same time. Now that a lot of the school and folks are back on site, it's not all back to normal. It's not like, they're all good, things are back to normal, we're feeling good. Like it's not that easy either. That whole year or 2 years or whatever time that they were virtual, that is trauma that they're still carrying today. And all that time that they lost socialization and the services and the education. And so I think that we as mental health professionals, social workers, nurses, we know that, but I think the world expects those kids to be okay now. And I think that's a big oversight.
Thank you for sharing that. I think, certainly, there's a large discrepancy in terms of how the pandemic is impacting, everyone, especially youth, especially youth with disabilities that have lost support and structure from school, among other services that have been restricted. So I want to transition into talking about suicide, which is what we know is the second leading cause of death for children and adolescents in the 10 to 24 year old range. I want to note that in the past few years or so, 10-year-olds became a high risk population for suicide. And that's been reflected in psych emergency room visits and just the population on the unit as well. And I don't think we know what's shifted. I think we suspect that technology might play a role. Certainly the pandemic, we know, plays a role. And I just want to note, with younger children, suicide attempts tend to be more impulsive than premeditative, like the older youth that we serve. And they tend to be more kind of associated with feelings of sadness, confusion, anger, problems with attention, hyperactivity, externalization of distress. And, want to note too, with the majority of children and adolescents, there's typically a underlying mental health disorder, usually depression. But there are, kind of small subset of the population where, suicide is not associated with any mental illness. In, kind of doing research at current statistics on suicide. In a high school, 17.2% of high schoolers thought about suicide each year, and then 7.4 had made one suicide attempt in the academic year. I tried to look up stats for Washtenaw County. I think the most recent are from 2020, so wasn't able to access 2021, 2022. We're still in this year, so that data wasn't available, but it looked like in 2020 there were 10 suicides for the age group under 25. And that is a rise compared to other years. But I do want to note that in the past decade, an increase in suicide attempts that really kind of preceded COVID. So that was something that was already on the rise. And we're not fully sure why yet, and why we're seeing an increase in suicide rates. I know we've talked about how the pandemic's kind of increased volume and acuity that we're seeing, but this was already, we already seeing kind of an uptick in this, and it, as an institution kind of planning for this in terms of increasing, those kind of first line resources. And then we're going to talk a little bit about this more extensively, but I want to note that kind of systemically, the media has an impact on suicidality. It's important to be aware of how we're talking about suicide across all media platforms. Just, an overwhelming amount of research shows that you're going to see a greater increase in suicide when frequencies of stories increases, a higher proportion of the population is exposed, headlines are dramatic, and the prominence of stories increases. And so the media does have the responsibility here to be reporting these things responsibly. So I wanted to share this, campaign that is affiliated with the suicide hotline. A lot of people don't know about it, but it's kind of the opposite of contagion. It's called the Papageno effect. And so what this is essentially a campaign that sparked guidelines for media to report more responsibly. Just because we've learned that suicide, with how it's reported, it's important. Responsible reporting that encourages stories of resilience and help seeking. It can decrease suicide and lead to increased help seeking behavior. So when details of positive coping during moments of crises are included in stories, it's protective. It has a protective quality for people who are maybe struggling themselves, and it leads to increased likelihood of seeking support. And so that could look like, calling a loved one, a friend, reaching out to a crisis hotline, engaging in your own treatment, positive use of coping skills. And we'll talk more about that later. But, it was found that when you are reporting the same suicide and incorporate myths, it leads to an increase in suicide rates and suicide clusters, which is an excessive number of suicides occurring in the close kind of geographical proximity. So when stories are seen by more of the population and the headlines are more dramatic or they're sensationalized, more kind of prominently displayed suicide rates may increase in that area. And so just an example, a study in Vienna found that with how Robin Williams' death was reported, there was a 10% increase in suicide rates. Just this was kind of across that nation, and so it does make a difference, and it's important that the media are kind of held accountable to how they're talking about these things. And so in terms of kind of reporting don'ts, you never want to be big or sensationalistic. You want to be careful about placement. You don't want to include photos or videos of the location or the method or the loved ones, or even the memorials or the funerals. You want to be careful about how you talk about the increase in suicides. And so actually, research encourages you not to use the word epidemic. or you know, talk about suicide as skyrocketing or other strong words. You don't want to describe suicide as without warning in the media. You don't want to kind of equate it to a crime. You don't want to say successful, unsuccessful, failed attempt. You want to be really careful about how you know, are reporting the suicide attempt itself. And you want to avoid interviewing or quoting first responders on the suicide cases. And then in terms of kind of do's, you want to inform the audience with minimal kind of prominence and sensationalizing. You want to maybe use a photo from like school or work. You want to include a hotline logo. You want to include supportive resources like the hotline numbers themselves. Maybe kind of investigate CDC data or the county's data, and really, again, kind of avoid things like skyrocketing, rise, higher. And then just really encourage, you know, help seeking. You know, that's a lot of information. And there's another slide on this. We're going to actually watch a video on a study in Vienna that looked at Logic's song, who is an artist who the title of the song was actually the suicide hotline number. And the video, I think, speaks for itself.
Autumn, before we move on to that, we had some questions in the chat. And
oh, I'm sorry, I totally missed those.
Oh, no, it's okay. You were busy. I thought maybe we could address them before, and it was just Randy was asking, you know, could we address a little bit about danger of not talking about suicide, or meaning not really assessing for it? And I think absolutely this comes up a lot. I think it's kind of one of those things, and maybe Autumn can chime in too. I still get parents asking me all the time when we are assessing and trying to safety plan and you know, provide psychoeducation on how to communicate with your child, you know, post-hospital discharge about talking about suicide and trying to make it part of their conversation. We still always get the question, if I bring it up, aren't they going to agree that or think about it more? I think I think we're going to come across that probably forever in mental health. I don't know if that will ever go away, but I don't. You know, I think what we've shown is that not talking about it doesn't make it not, you know, it doesn't help anything, right? And I think even from not assessing it from like other kind of discipline, right? So even if we're in mental health, of course, we tend to always assess for it. But, you know, if you're a pediatrician or a school teacher or something like that, it could always come up in other ways that people could start assessing this on their own in the community. By simply just asking a question, whether, and not have it be too leading, but just, you know, do you feel safe? And if not, like, are those thoughts referring to you wanting to hurt yourself or maybe make an attempt to end your life? And I think having those conversations, the more information you can obtain from that adolescent could save their lives. So I think not assessing for it or asking brief conversations or having brief conversations, no matter what discipline or how you're coming across this youth, is always important. Doesn't mean that you're going to treat it or solve it, but you can at least make the next steps on like, what should I do next? And which we'll kind of go into later in our presentation, like when you start seeing these warning signs and assessing these things and what should you do and what kind of resources should you refer to? Yeah. And I don't know if Autumn wants to add in anything else. If that helps answer your question, Randy, I'm not sure.
I thank you for that question. It's imperative to give, you know, youth, as Emily said, youth space to talk about these things. And oh, sorry, I didn't mean to. I'm having some hard times with the hosting features. And we know, you know, too. I just want to touch on one last thing on this slide. That research shows when details of positive coping during moments of crises are included in media covering suicides, it helps protect others. Let me see if I can get this to play now.
Autumn, we can't hear the sound.
Thank you for bringing that to my attention. I wondered about that.
Go ahead and unshare for a second. When you
Okay.
reshare your screen, select the two boxes at the bottom that say share with optimal voice and video or something like that. There's two boxes.
Okay.
Do you see that? When you click share screen and then it should.
So I see advanced sharing options.
It should just be two boxes at the bottom that say share sound and optimize for video clip.
One moment.
All just at the bottom of that where it says select a window.
Oh, I see. Okay.
Yeah. Okay.
Thank you.
Yep.
Okay.
You should be good now.
If a very
Okay, is that working for everyone?
Yes. Great.
Okay, perfect. Oh no. I am so sorry. One moment. How do I start? Okay.
You're fine. No worries.
Share screen. Can you hear now?
Yes, you're great.
Okay. Phew. Okay.
For suicide prevention, it is extremely important to better understand how different messages about suicide and suicide prevention relate to help seeking and suicide in the population. In this study, we focused on a very specific narrative, a very specific message, Logic Song 1-800-273-8255, prominently featuring the telephone number of the national US crisis service, the Lifeline. This narrative is very unique in two regards. First, it's a song, very different from the traditional prevention messaging. And second, it does not focus on a suicide death or near fatal injury. Instead, it's not even about suicide. It's really a story of hope and resilience. It depicts a young black man who is bullied for being gay and considers suicide, but then takes the phone and calls the crisis line, which marks a turning point towards improvement. And this is a classic story of hope and recovery. We know for quite some time already that specific narratives about suicide death are associated with imitation effects, which means they are associated with increases in suicides in the population once they are reported. This is particularly the case when it comes to the reporting about celebrity deaths from suicide. Recent data suggests that after the reports about celebrity suicides, there's an increase of 13% in suicides in the population in the month after the reporting. And media guidelines for suicide reporting are the means to really mitigate the risk of such narratives. So we know from studies that by far not all messages about suicide and prevention have harmful effects. Instead, there is relatively new findings, particularly from experimental research, so from randomized controlled trials, which suggest that narratives that focus on hope and recovery, just like the Logic Song, reduce suicidal ideation in vulnerable audiences as compared to control groups. A main gap in knowledge, however, has been that these types of stories typically do not get a sufficiently large audience in order to make broad behavioral impacts across a population. And the Logic Song was really a unique example of which is different because it really yielded a large, sustained footprint in the population and in the media. So we found that during periods of large public attention to Logic Song, there was an increase in calls to the Lifeline. It was more than 9,000 additional calls to the Lifeline, which is an increase of about 6.9% in this 34-day period. And during the same period, there was also a drop in suicides 245 fewer suicides than expected, which is a drop of 5.5%. So these findings are really of crucial importance for suicide prevention because they highlight that stories of hope and recovery can have a strong behavioral impact in a population in terms of help seeking and in terms of reducing suicide. And the findings also suggest that it's of crucial importance to collaborate with other sectors like the entertainment industry and creative arts in order to develop powerful narratives that resonate well with diverse audiences, just like the Logic song.
Okay, so we were thinking that we could allow, everybody have a break. I'm not sure, Michelle, if you have a suggestion of how long that should be.
It's up to you both to know how much you have in terms of your next part of your presentation, but do you guys want to do like 7 minutes and come back to you at 2 o'clock? Would that work for both of you? Give you a little bit of a breather for a second?
Oh yeah, that would work for us. I just want to make sure other people are feeling comfortable too.
It's important we do some self-care too today, so yeah, definitely.
Yeah, I think we definitely have, I think we'll definitely have enough time and to include, like, we have a few things at the end that we can definitely change up if we need to. So, or now that it's 1:54, we could just make sure maybe everybody could just come back at like 2:05.
Okay,
To give enough time.
that sounds good.
Okay,
Thank you.
thanks everyone.
I just want to confirm, can everyone see the PowerPoint?
No, we see your Google
Okay.
Drive.
I see.
There we
Okay,
go. There
There
it
we
is.
go.
It went
Okay.
back.
This full screen. Okay, sorry.
I wanted to thank Autumn for kind of taking on the technical part of this presentation. It's something that we're worried about. So thank you for being patient with us. So kind of moving, still on the topic of suicide, but we really want to start like looking at how we assess it, right? And of course, these risk factors, as we're looking at child and adolescents, you could easily be translated for adults. So with the risk factors, risk is conceptualized as a biological, social, and psychological areas of a person's life. So all those things have to come in consideration. As we have, you'll see over the next 2 slides, there's lists of things to consider, but it doesn't mean that this is limited to this, because of course, in some of our careers will come across a once in a lifetime story. So I don't think that any of this can be just limited to this list, but furthermore, we'll go on. When we look at these areas of change for adolescents, you look at education, school avoidance, loss of academic achievement, increase in dropout rates. From a health perspective, definitely physical and emotional things that could be warning signs that there is some kind of risk or concerns going on, like stomach aches, headaches, sleeping issues, increased in depression and fear and anxiety. And then from safety perspective, like, are we assessing to see if this person's a harm to themselves or others, or including self-isolation or aggression, alienation, and retaliation? Looking at suicide, and especially when you're dealing with adolescents, it could come from all different avenues. It could be that they want to retaliate about something, and this is what they're using to cope with that, or wanting to escape. It doesn't necessarily mean they have intent to die, but they may act on preparing for a suicide attempt, or even a self-harming behavior. And then sometimes, some people also use it for manipulation. And then also, of course, we come across people with significant mental health issues that this is could be a product of that. As well as what I think Autumn said earlier in our presentation is, like, sometimes suicide is not always connected to mental health, right? You don't have to have a pre-existing condition to have suicidal thoughts or even have a suicide attempt. And then we also look at, as you can see on the list, family history of suicides and mood disorder, previous attempts, what is their history of mental health? Is this a clinical depression that we're looking at? How hopeless are they? Is it impulsive or planned, or it was during like an aggressive episode? Sometimes we often hear, whether you're assessing a child in an ER or from an inpatient setting, like, in that moment, I said these things, or I meant these things, but I don't now. So cultural and religious beliefs also, what is that person's religious belief on suicide, local epidemics of suicide, loss of relationships, death, bereavement, social interactions, work, financial, more from the adult perspective. But as you're transitioning into adulthood, we often come across on the unit, especially with, like 16, 17-year-olds, like, if they don't see a future for themselves transitioning from the adolescence, from high school into the future, that they might become hopeless and feel like, there's no point. So I often hear about that coming from our patients. And then, of course, we still have to look at access to lethal means, unwillingness to seek help, or stigma attached to mental health and substance use disorders. And I think, of course, we still have to always consider trauma, what kind of conflict or relationship discord they're having amongst their family or other children or peers, or even, school personnel. Or lack of, if you will, like those that don't feel connected to anything or anybody. And sometimes that comes from just what they've experienced, or even if you have patients that have, what we would consider reactive attachment disorder, where they don't really know or have that ability to do so, to attach themselves to peers and family supports. substance abuse and alcohol abuse, we know escalates risk for suicide, especially if they're under the influence. Yeah. And then also, of course, which I think we spoke about before, lack of resources or the ability to obtain mental health services. So I think we can go on to what comes after risk is kind of identifying, more things contributing factors. So I don't know if Autumn, if you want to go through this flow chart for us.
Yes. So I thought this was just a nice kind of visual to kind of walk through, what we're kind of talking about. And so we've talked about, mood disorders, things that can kind of underlie or make you more vulnerable to, suicidal ideation, experiencing suicidal ideation, and if things kind of escalate to the point of a suicide attempt. So just different things that can kind of underlie, suicidal ideation. The catalyst would be, a stressful event. So with youth, that could look like bullying, loss, difficulty in school or with the law, we'll see. And so that can lead to, acute mood change. So really intense anxiety, dread, hopelessness, anger, hostility, and then that, I'm sorry, I have this text box that's in the way, can either lead to facilitation or help seeking. So you'll see that with available support, recognition of the problem, seeking support, accepting support, treatment, positive coping strategies, and safety proofing the environment. So not having access to lethal means can lead to survival, where if there's means to facilitate that can result in a suicide attempt or a suicide. And so having access to weapons, medication, ropes, sharp objects, and not having, support and services to prevent. And we're going to talk through this as we kind of continue on. I just thought that this visual did a nice job kind of walking through contributing factors to suicide. There's so much there. And so it's kind of the combination of all of these things that might lead to a suicide attempt. And there's a little bit of a delay when I change the slide, but it should hopefully be changing here shortly. Try it this way. There we go. So we've talked about risk factors and what might make someone vulnerable, and typically it's kind of a culmination of things. But it's also important to talk about protective factors, and this is something that we're also assessing for, with that first line kind of intervention, maybe in the psych emergency room, but then also while we're treating patients when they might come inpatient. And then two, outpatient providers are also making these assessments each time that they meet with a patient, especially if they're suicidal or profoundly depressed. And we know, protective factors can help buffer individuals with suicidal thoughts and behavior. You'll see that this slide is much shorter than the risk assessment slide, which was two-parted, and that's because it hasn't been studied as rigorously. And these protective factors, they look different for everyone. I just want to kind of highlight this is not comprehensive, just some things that we're maybe kind of assessing and keeping a pulse on and trying to bolster. We know that when assessing for suicide, it's equally as important to assess for resiliency and protective factors, and to try to kind of provide scaffolding and identify internal as well as external support. So this is by no means exhaustive. These things are unique to everyone. And the goal of identifying protective factors is to, find ways to mitigate risk factors really, and bolster support. And so some of this will, we'll look at kind of access to care, what's the quality of the therapeutic relationship, if there is one, family support, community support. It truly does take a village. Support from ongoing kind of providers, skills in problem solving, communication, cultural and religious beliefs, milestones or life experience. You're really going to be wanting to gauge someone's future orientation, sense of purpose. And then two, is the person that you're kind of assessing or the individual you're working with, do they have genuine reasons to live? And so, again, this is by no means exhaustive, but a really kind of important part of the evaluation process.
So moving on from suicide to self-injury, oftentimes, people are not quite sure what it is or what that looks like, or even how it even relates to suicidal ideation. And sometimes patients experience both, or they're very clear about that they're experiencing one over the other. So I think it's always important to assess that and then can go from there. So, just we'll do a brief little examples of what self-injury is. I'm sure some of you are pretty privy to this, but, cutting, scratching, pinching of the skin enough to leave a mark, banging or punching objects or self at the point of bruising or bleeding, ripping or tearing of skin, carving words or patterns into skin, burning skins with cigarettes, matches, or hot water, or lighting things on, and then touching them to their skin. I think also oftentimes, like even in younger kids, you'll see eraser or ice burns. And to give an example of some pretty severe cases I've come across in my career is that, I have come across patients that they actually did rip or tear their skin, and one adolescent who had a history of pretty significant trauma would pull at their labia so much that they had to have medical interventions on those parts of their bodies. And as most patients, the why is all different as well. Some, and so some are just trying to manage their painful feelings or current and past trauma during this, and they use this as a distraction, even though it is causing injury to their body. Sometimes they use it to feel the pain because they may be experiencing a sense of numbness, and want relief of that numbness. And so this is the only option of this maladaptive coping kind of mechanism that they've kind of obtained throughout their life. Punishing themselves, right? I did all A, B, and C, therefore I must deserve to feel this. Exert influence over others. So that could be we often see even in adolescence, right? Sometimes threats of self-harm, whether that's, in front of another person, whether it's their family or peer, or via text message or social media. We've often seen a lot of that happen on social media, right? Kids placing their distress out there, and even showing pictures and stuff like that. Which, kind of goes from the previous part of our presentation, how does that affect their other peers, but also could be a sign for help, and they could ultimately get some help out of it. So it's kind of like the catch-22, right? Are they going to influence others versus get their own treatment because they're putting it out there? Sometimes they're, patients that unfortunately have experienced some trauma, they're trying to end feelings of that reality or even detach themselves from it, or to even avoid suicidal thoughts or even more significant feelings that they're having. So sometimes we'll hear from patients say, why self-harm? To avoid my suicidal thoughts, because if I don't do this, then I'm going to start planning on this. So they're kind of all connected. And then studies show about 13 and 25% of adolescents and young adults surveyed in schools have some history of self-injury. And of course, this has escalated over time. I think it's definitely something that is increasing, and I don't think it's going to decrease at any time. Until we're able to kind of implement other services that can help people cope with more positive coping skills, whether that's in actual treatment or having some kind of system throughout where we're reaching kids and giving them some brief interventions that they can start trying as soon as we start to hear of these things. Yeah. And I think we have some more on this. So kind of looking at self-injury assessment, again, wanting to clarify first if this is a suicidal thought or kind of situation, or is it self-harm, or is it both? Some adolescents or children will often say, well, it started out with me feeling suicidal, but then as I started to self-harm, I realized that I had no intent of wanting to die, but I continued my self-harming behavior. Is this and the most important thing to assess that is to validate their feelings, meet them where they're at, listen to what they're saying, and not jump ahead to the problem solving and coping skills right away. That will come later. But first to validate the behavior. And then if you're working with a family, help the parents or family members or guardians understand what is actually happening here with this maladaptive coping that they're doing. And oftentimes, depending on the situation, or either they're very privy to what's going on, or and some families have no history of even coming across what self-harming behavior is, and that differs depending on the patient and their family. Listening before offering an opinion, which I've already just mentioned, and then and some of the things, being respectfully curious about what they're experiencing, and kind of asking simple questions around that, like, what does this do for you? Does it do anything? Does it provide anything for you? And kind of further explore where is it first coming from, or where it was initiated from, and then also kind of going into like the more specifics, which is like asking more further questions about, what does that self-harm look like? Oftentimes from a hospital's perspective, if it's in the ER or even getting to the inpatient level, we've already kind of addressed it, right? We've seen what it is. We've kind of addressed the injury on the body and maybe provided medical treatment. And then really from a treatment perspective, we're really just trying to figure out, like, what does this do for the person? What are they trying to cope through? And then how can we, intervene and provide more positive coping skills, and trying to train them that there's other alternatives. Yeah.
And then just to kind of build upon what Emily's started to discuss, which is how to kind of intervene. It can take a long time for a person who is maybe using self-injurious behavior as a means of coping to discontinue. It's important to encourage individuals by acknowledging each small step as a kind of a major achievement. So examples of this might be harm reduction. That could look like washing implements that are used to self-injure or cut, taking better care of the injuries, cleaning them if that's what it requires, bandaging them, and then, sometimes stitches, and then providing space for the individual to maybe be distracted, kind of notice the thought or the urge, but then make the commitment to delaying, acting on the urge or the impulse, whether that be, 15 minutes, half hour, an hour, and then, ultimately, encouraging them to reduce the severity or the frequency. So some helpful ways to help teenagers avoid hurting themselves, or anyone really, is, helping them to kind of accept reality and find ways to make the present moment more tolerable, identify feelings and talk them out rather than acting on them. So, like I mentioned, reminding them that a thought is just a thought. You can't control your thoughts or your impulses or your urges, but you can choose how you respond. So distraction, that can be really powerful when you're struggling with thoughts to self-harm. And so maybe encouraging, them to use kind of alternate ways of coping, like grounding, delayed distract aside is a skill that we often teach our kids here on the unit. So making the commitment to fill the time with something maybe more adaptive, and then making the choice of whether or not you self-injure, positive imagery, meditation, deep breathing, using ice or rubber bands, which we do this skill. It's called TIP. It's a DBT skill, but it involves holding ice, which has a kind of numbing sensation. It's a bit of a sting, which can kind of emulate what self-harm might provide for some individuals. And so that can be, it provides this as comparable kind of physical sensation, but has kind of a better outcome. So that can be highly effective as well, introducing those skills or encouraging individuals to practice those skills. Sometimes it can be helpful to provide space for individuals to identify pros and cons of self-injury. Really important to take a very kind of non-judgmental, empathic approach while discussing, and really just encouraging individuals to soothe themselves in a positive way that maybe aligns more with their long-term goals. Really, too, as Emily said, self-injurious behavior doesn't always mean suicidal ideation, and so continuing to monitor for suicidal thoughts and understanding really, self-harm can be, a function of something different, a means of coping. And we just wanted to include a list of location of assessment and intervention. And this is true for self-injurious behavior as well as suicidal ideation, which we've talked about. And so school, kids spend 5 days a week during the academic year at school. And thankfully in Washtenaw County, our schools tend to have a higher level kind of support and people that can kind of monitor and take care of these things. I know formerly we had trails to wellness in a lot of the schools, and that sounds like that's kind of transferring outside of U of M, and I'm curious to see kind of how that continues to grow. We have the ROS clinics. Schools are staffed with their own counselors and social workers. Outpatient therapy. Of course, suicide assessment should happen at every session, really. Pediatricians, primary care, because of the kind of state of mental health across the nation. And this is one of the other New York articles or New York Times articles I was referring to. The PCPs, pediatricians, have seen a huge uptick in patients who are struggling with mental health, and then because access to care is so challenging, they're treating a lot of the patients who maybe are struggling with something like depression and anxiety, and managing a lot of medication for those populations until they can be seen by a psychiatrist, if they can be seen by a psychiatrist or a mid-level provider. And so suicide screening, self-injurious assessments, those are happening at PCPs more often than they had been previously. Of course, the hospital setting, and then really this should be screened for during kind of routine medical care and procedures. That's typically included in part of the screening process, as well as emergency rooms if there are emergent concerns as it relates to mental health, suicidal ideation. And so not sure if everyone on this call knows that U of M has a psych emergency room that's specific to patients who are in psychiatric crisis. Otherwise, and I think Beaumont has one as well. Otherwise, emergency room settings also are going to be a location for assessment and intervention. And you might not always have, specialized kind of subsection like we do here, like what Beaumont has, but staff, ER physicians, and then their social workers should be trained in this. Community centers, juvenile justice system, jails, summer camps, and then we talked about emergency rooms. Hopefully we play this video without incident. This was taken from Trails, which I know I had mentioned, which was grant funded through U of M, providing increased kind of mental health support in schools across the county. But it's through the teen suicide prevention through Mayo Clinic. Hopefully this shares with volume. If someone could just let me know if they can't hear, that would be great.
We can hear it. You're good.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy.
I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual,
Acting really down, crying all the time for no good reason.
Or getting really mad. Not able to sleep, or sleeping too much.
Shutting her friends out or giving her stuff away.
Acting reckless, drinking, using drugs, staying out late.
Suddenly not doing stuff he used to love.
or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed.
Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself.
It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish he'd said
I
something.
wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask.
They want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask.
In fact, the best way to keep a teenager from killing herself is to ask, are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes,
Well, here's what you don't say.
That's crazy.
Don't be such a drama queen.
you're making too much of this.
That boy's not worth killing
Yourself.
over.
That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself.
What you do say is,
I'm sorry you're feeling so bad. How can I help?
We'll get through this together.
Let's keep you safe.
A lot of people think about killing themselves, adults and kids.
most of them never try it, but some of them do. So if your kid says,
I'd be better off dead.
I can't live with
I'm
this.
gonna kill myself,
Take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Sometimes kids want to kill themselves because something happened. A breakup, a failure. But sometimes it goes deeper, and it's not going to go away by itself.
Get some help. Talk to your doctor.
Or a counselor at school.
Or your minister.
but don't just let it drop.
And make sure that your kid always has someone to turn to. Someone he trusts.
Make a list together right then. 3, 4, 5 names.
Put a suicide hotline number on there too.
Have him keep that list in his wallet, so he always knows where to turn.
Make sure your home is safe.
If you have pills she could use to hurt herself, lock them up.
If you have a gun, don't just lock it up. Get it out of the house. The bullets, too.
And one more thing. If you think your kid might be about to hurt himself, don't leave him alone.
Take him to the emergency room.
Call 911 if you have to.
So sorry.
I am my.
Hurt himself, don't leave him alone.
Take him to the emergency room.
Call 911 if you have to.
We all have our ups and downs, but sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Ask straight out. Are you thinking about killing yourself?
Don't wait until you're sure. Trust your gut.
Because it never hurts to ask.
And it can make a big difference. All the difference.
In your kid's life.
So kind of moving on from that, and I think that, again, addressing some of the questions that came up earlier, like, like what not to say or not addressing it is not usually what we should do. So when we're thinking about, a suicide assessment, and of course, this comes in many ways depending on your discipline, but one of the important things I've learned over time is that you need to ask more than once, because sometimes it's going to take that patient a little bit longer to be able to speak about it. And you can ask in different ways. And especially with children, especially the younger ones, they may not actually understand the concept. So you have to kind of put it in more of some basic language. And kind of really understanding what they meant when they said that they wanted to kill themselves. Because oftentimes, even though they're saying it, they may not actually get the concept of what they're actually expressing. So as you can see, there's some examples of, how to question if somebody's having suicidal thoughts. And then, of course, you want to continue to assess those risk factors and protective factors that we went over earlier. And then also what's influencing, right, is contributing to the risk assessment. So what's driving the suicidal thoughts? Is there a trigger? Is there a breakup? What's going on? Is it just the depression? Are they very intrusive, or are they easily to distract from? Does the patient romanticize or fantasize about suicide? Is there any sudden movement of changes in mood? Are there other preparatory acts, right? A lot of people say, oh, they wrote a note, or they gave this away, or and right now it's the big thing is sending out goodbye messages via text or social media. And of course, lots of, I think, professionals do use the Columbia Suicide Severity Rating Scale to kind of assess these things, because it does break it down in a nice way of how to question things, as well as to distinguish, what's the difference between, suicidal intent versus a preparatory act. And then on top of that, what's the difference between an aborted, interrupted, or an actual suicide attempt. Those all look very different. There was a question.
Yeah, I just threw a question in the chat there. I've had some childcare providers talk to me a little bit about like negative self-talk among younger kiddos, like 5, 6, 7-year-olds. I was just curious about your suggestions or support that we can provide those younger kiddos to have those conversations about their big feelings, because I mean, they're even saying things like, I would be better off dead, or I'd be better off without my family, or things like that. And those are really hard to hear from little mouths. How do you best support those kiddos?
Yeah, I think that's a great question, because it does look very different, and they are big words to come out of those little mouths, that just like you said. I think stepping back and trying to label their emotions is where I would start, and maybe Autumn can chime in too. So labeling the emotions is usually where I start, because oftentimes they're trying to express emotion and it's not really that they're suicidal, or they even they even understand or the concept of suicide, or even death, right? How permanent it is. So I always kind of roll it back and say, like, let's kind of start, what did you feel first? Let's label that and then go from there. And oftentimes, I do this with the parents in sessions, because so they can understand and hear this, because parents often don't know what to ask or how to explore it. So I think starting right there with them so they can hear where it's coming from is the best bet. And usually that will cover like the intent, or like some contributing factors as well. I don't know, Autumn, do you have anything else?
I would just add further using age appropriate language.
Yes.
So how you talk to a 4, 5, 6-year-old about suicide is going to be very different than how you maybe talk to a teenager. And so making sure that you're being developmentally appropriate. And then, as Emily said, helping them to label kind of emotionally what might be happening. And too, like that indicates to me that maybe there's fears or worries, and suicide might be a form of escape. So exploring that, what is so distressing in your world that's leading you to consider these things and to verbalize these threats.
I also wonder about, can I add something? I also wonder about some social emotional curriculum that can be done preventatively, about, labeling emotions, like you were saying, and doing things about, these things make me mad. This is what I can do when I get mad. This is who I can seek out when I'm, feeling upset or mad. So some of that preventative curriculum that can be done in childcare settings.
Absolutely. And I see a question about resources, and certainly we can follow up with educational kind of handouts or support that we might provide families that we service here on the unit. Emily, are you ready for the next slide?
Yes.
One moment, there's again a bit of a lag. There we go. Oh, okay. So I actually think this is my slide. So we want to be mindful about time. But in terms of kind of interventions, and we're going to talk through this, but kind of first and foremost, we a plan of action in a safety plan. And so kind of first, what we're going to look at is, what level of care is maybe indicated here. And by level of care, we mean, outpatient therapy, the psychiatric emergency room, or just a local kind of medical emergency room for evaluation by a professional, something like a partial hospitalization program, which is the day program. It's kind of a blend of outpatient and inpatient hospitalization, and then inpatient hospitalization. It's going to be imperative to coordinate care with whatever professional may be making a referral, whether that be school personnel, outpatient therapist, family friend, parents. There are lots of different ways that kids might come into the emergency room for evaluation, whether that be the parents noticing a decompensation in a mood, school reaching out and sharing concerns, therapists, recommending that they come in, etc. I just wanted to kind of note duty to warn, with HIPAA, with outpatient providers are kind of bound by federal law regarding, their sessions. They're confidential unless, someone's an imminent risk to themselves or others. And so that's true for, suicidal ideation and homicidal ideation. And this is typically discussed pre-treatment with youth and families, and something's typically signed that families understand that in the event of, someone being in kind of imminent danger to themselves or others, that's when you have a duty to warn and violate HIPAA to get someone support. You really want to kind of be assessing or parents understanding the risk, and are they willing to access local referrals and crisis supports that we may provide. When patients are a moderate to high risk, we want an outpatient follow-up appointment scheduled as soon as possible. In our unit, we require when we discharge an appointment within 7 days with an outpatient provider. And this really is because the first kind of 2 weeks post-crisis or suicide attempt, that's the most vulnerable time, the most high-risk time, and we really want to heighten, youth support, including, parental support or, caregiver support, whatever that looks like, social support, and then professional support. We're gonna talk through more, safety planning as we kind of proceed on here. Here we go. So safety planning. And so a lot of the kind of psychotherapeutic interventions that are evidence-based with crises are things like cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing. And these are evidence-based for things like depression, anxiety, and suicidal ideation. And so in terms of kind of crisis tools, we're really wanting to help the individual kind of shore up a plan that's very kind of comprehensive to manage through the distress, the inner distress, or the thoughts that they may be experiencing. And I have we're going to kind of go through, and we have some kind of examples of what this looks like. But if you come into the ER, you're going to likely there some options. But if you're discharged home and kind of diverted to a lower level of care, safety planning is part of the discharge process. If there's an acute kind of safety concern, if there's something like, increase in self-injurious behavior or suicidal ideation, and someone needs increased support. And then part of discharge from our program, every patient has to kind of develop a safety plan and review it with their parents, and everyone has to be kind of collaborative and on board and feel equipped and prepared to manage through future kind of crises or future kind of exacerbation of depression and suicidal ideation. So the hope is that kids have some kind of access to relaxation techniques, distraction strategies, or crises kits or healthy adaptive coping skills.
So kind of to go off of that, as kind of Autumn was discussing, is, you know, what to kind of include into your safety plan, right? Because this is a collaboration. And usually it's amongst, especially with children and adolescents, with the professional, as well as the parents and the child. So it's all of the above, right? Because it's going into your, especially if you're transitioning out of the hospital or from a level of care home, everybody needs to be prepared what that's going to look like and what changes are going to happen. So the plan should always consist of, like, you know, being aware of crisis resources, right? Hotlines, emergency departments, how to access your providers if it's after hours, if there's something that if they have some kind of after hours programming. And then really understanding when you're going through these safety planning assessments with these family and kids, is that they really need to understand, what do those warning signs look like? What are contributing factors? What are triggers to the suicidal thoughts? Or in a small child, like we were talking about, what are those emotions that lead up to those statements? And then how we can assist parents and the child to communicate over those things, like how do you question your child in those matters to better understand and explore, like, are they actually suicidal, or are they distressed over something else and they're using that language to express that. And then they can identify their coping skills of what they're going to use in those times of distress, right? Whether it's distractions or like what Autumn was talking about, like as in like our tip skills, using ice cubes. What are going to be your people that you're going to reach out to, whether it's social, professional, or family. And then lethal means education. Lethal means, you know, in terms of like locking up medication, you know, removing or making sure firearms are locked and stored safely. And sometimes with pretty severe self-harming behaviors, how do we restrict that, right? And we're not expecting homes to be like a hospital setting, but it needs to be improved to the matter that they're at least giving them some time, if they are having urges or significant emotions or feelings, to give them a little bit more time to actually have to reach out for help before they have the access to those means. And then kind of going into some of our other parts of our presentation is like, is there consideration for using a safety plan app and suicide prevention apps that could be helpful for the family? And for the sake of time, you know, referring to a local emergency crisis, we would probably usually go over this if we had more time, of like what kind of things is appropriate to refer to the ER and what probably could refer to outpatient. But right now, I think with the state of like not only Washington County, but in the state of Michigan and probably across the United States, it's really hard to probably have access to other resources to help assess these situations besides crisis or emergency rooms. So I know you'll have access to this presentation and maybe you could review this on your own, just that way, you know, but I think if anybody's questioning if a child or an adolescent is suicidal, is to refer the family to an emergency room as soon as possible so they can assess further and kind of determine if that person needs a higher level of care.
Just real quickly, wanted to kind of shed light on the fact that, you know, it is 2022 and most everyone has a smartphone, including a lot of our teenagers. And so I think, you know, that can be used to our benefit. There are a lot of apps out there that help kind of walk, you know, individuals through things like mindfulness, meditation, distraction, coping. And so, you know, encouraging people to kind of take advantage of that. You know, crisis lines, of course, you know, that's important. You can call, sorry, on my phone's off. You can call or text a lot of these lines now. We didn't include it in the presentation, but U of M also has their own crisis line through the psych emergency room, which families sometimes feel safer calling just because it's more kind of local and they know they're going to be speaking with a University of Michigan clinician, and that's 24/7 as well. And so, yeah, you know, if we'll send a copy of the presentation out and you can kind of explore all these different apps and encourage, you know, whoever you may serve to take advantage. This is a screenshot of the suicide safety plan, which really kind of mirrors, you know, safety plans that we might do in the ER setting, as well as safety plans that we help our patients complete upon discharge from our program. So really neat resource. And this is some screenshots of the virtual hope box, which is kind of rooted in distraction techniques. As you can see, word searches, photo puzzles, stuff like that. I think this is your slide.
Yeah. So, of course, you're going to come across challenges with any child and family that you're working with, especially in psychiatric crises. And that can include to language barriers, culture and ethnicity. What are their beliefs on mental health, and trying to navigate that system in a respectful way, or the family's perspective of it. Because oftentimes, their perspective and the perspective of the child is much different. And we have to help them kind of realize and understand that. And along with that, it comes, with what is the family dynamics currently, right? Is there a divorce? Is there pathology coming from the parents? Or even, even if they're willing to consent to treatment, sometimes that's a barrier, just to have them understand what the need is at this time. And if they have any insight into mental health or suicide or self-injurious behavior. And also including, some things to also consider is just access to the availability for crisis intervention, right? Transportation, insurance, co-pays. Is this child a ward of the state or in the juvenile justice system? Like, what is their access to being assessed? And then how can we even plan interventions? And so these are kind of some things to consider when you're looking at the challenges. And I know we heard earlier about somebody saying, rural versus city. And I think each side has its faults and difficulties managing that as well. Across the board, I think we've talked about this multiple times, is that it's really hard at these times with resources and just the workforce not having the capability to have any providers being available to assess situations.
And I wanted to just take a moment to, kind of acknowledge that not all mental health problems can be solved in the therapy room. They have to be fought at a social and political level. And we know that all of the kind of above issues impact mental health and make you more vulnerable to, psychiatric kind of crises and subsequently, suicidal ideation and attempts. And this is by no means kind of comprehensive, but again, that, things that we need to consider, if we're not combating these things at a systemic level, how can we expect people to be well and to be safe? And then
sorry, Autumn, really quickly, just can you speak at all to the importance and value of even us as professionals taking care of ourselves, because this stuff is so heavy. It's really important that we're also making sure we're taking care of self. So ideas.
So agreed. I think in order to serve others and to avoid burnout, you have to be well yourself, taking care of yourself. And I think that extends beyond like an interpersonal level. I think you also, in your place of employment, need to be taken care of by your employer. And so that looks like, being paid fairly, being so fairly compensated, having good time off. So you can nurture your identity outside of your job, having space at work where you can talk through the really kind of hard, demands and responsibilities that you're juggling in your day-to-day. What does your kind of supervision look like? Oftentimes supervision is more kind of administrative, but I am a big believer that there need to be reflective spaces where we're able to kind of touch on or tap into like our own kind of emotional reactions to these things. And I thank you for bringing that up, because suicide especially, that is a very emotionally charged topic. And, Emily and I are doing this 40+ hours a week. And I can appreciate, the work that everyone else on this call does today. But I think, taking care of yourself on an interpersonal level is imperative, but also, I would encourage you to kind of question, how does my employer take care of me? What benefits do I have? What does my support look like? And is this kind of sustainable? I don't know, Emily, if there's anything that you'd add or if that answered your question.
I think you kind of summed it up pretty well. And I think sometimes really understanding and setting your own boundaries is imperative. I think, especially in social work, but in general, especially when we're dealing with such heavy topics, because if you don't learn how to set those boundaries as you go along in your career, then it's going to easily bleed within and out your life. And so you have to be able to, I don't want to say compartmentalize, but you kind of have to, right? And set those boundaries and stick to them. So you are taking equally care of yourself and your own family. And so you can be there to support these families and children. Because if we're not well, how are we going to get them well? And this slide's just basically a brief kind of overview of like the hospital services, which I think we kind of talked about already. And each community is different, but like in our community here at Michigan Medicine, we have different levels of how we assess mental health throughout the hospital system. And we apologize because I think that we really were not did not provide enough we did not provide enough time to actually go into some case studies to have you guys use some of the skills that we were teaching about, whether it's in assessing risk when it comes overall, with some case studies of children and adolescent presentations that we see when we're dealing with mental health crises. And so I do apologize for that, but I think if there's any other questions or concerns or other topics, we've touched on self-care that other people would like to bring up versus trying to quickly go through a case study.
I know there's some people just saying in the chat that they are very appreciative of your presentation. So I want to make sure that kudos go out to both of you for this, all of this great information. And then also just to remind everyone to sign out. I know a couple of people have already said they had to leave a few minutes early to get to their meetings or their sessions that they have with other folks. So please take time to fill out that survey link that I threw in the chat, and make sure you put your name in the chat so you have those CEUs coming to you. So just wanted to throw that out there before people log off.
Michelle, this may be a lame question, but do we have to fill out the survey, Autumn and I, to get CEUs?
You don't have to. No, I just need you to put your name in the chat so that it's noted in there. I mean, obviously you're here because you're presenting, but NASW is kind of a little particular.
Yes, I'm pretty sure I did.
Michelle?
Yeah.
When I click onto the link, it
Yeah.
defaults to the Child Protection Team email, not mine. And so it says something about, are you switching accounts? And then it says, I can't switch accounts.
Here, let me change the settings for a second, okay?
Or you can email it. I can do it later. I don't have to
Okay.
do it right this minute.
Okay, you can do it later, that's fine.
Okay. Autumn and Emily, you guys did a really good job.
Yes.
Oh, thank you. Yeah, it was a little stressful to try to pull this all together, but I feel like we know now for next time.
Yeah,
Oh, no.
well, yeah, this was great.
No, you guys did a really, really good. I feel bad because the second half was what I really, really wanted to hear. And of course, I started getting called and paged and whatever, so. But I'll look at the slides.
Yeah, and that's good feedback, maybe focus on that a little bit more next time. Yeah.
I even wrote down a couple of ideas. So we're part of the Washtenaw Live Suicide Prevention Group. And so I was really interested to know if there are particular media outlets that you would suggest I reach out to attend one of our meetings so that we could discuss about that whole intentionality about how they're reporting suicides in our community, because that's been a very hot topic in our community, that number one, things aren't being covered, and number two, they're not being, when they are covered, they're maybe not covered the way they should be. So we've really had that as, it's been a topic for at least the last 6 months, if not a year, in all of our meetings. So I'm glad you brought it up, because I hadn't really thought about, let's bring them to a meeting and let's talk about this.
Yeah, and kind of go over, you know, guidelines. So I would say MLive, and then Detroit Free Press are what come to mind. And I saw Detroit Free Press, and I just didn't have time to update the PowerPoint, but they did a really nice job reporting on a suicide of a youth in the Detroit area recently. They like, I was kind of going through and critiquing, and I thought, oh gosh, like they talk about resiliency, they talk about help seeking. They were not explicit in regards to the attempt and method. And I almost, it was on Twitter that I saw it. I wanted to message them and say thank you.
Yeah, that's awesome.
Yeah.
And then the other thing that I'd like to share with that group is that video on the trails, the Mayo Clinic video. So as long as you guys send me that link, that'd be great.
Yeah. So we'll send out the link. Oh, did you send it already, Emily?
Well, I thought it was this last link here on the screen.
Oh, so that's just Trails to Wellness in general, which I think they're in the process. They're separating from U of M, which is a whole thing. But they're in the process, I think, of making a lot of their information private, which is unfortunate because they have a lot of great stuff. So I can send the direct YouTube link. And then, yeah, I encourage everyone, whoever's still on, to go through the Navigating a Mental Health Crisis webinar series that was put on through NAMI and Washington Community of Mental Health and U of M. It's, I think, from like October or November from the fall, but U of M archived it so people can watch recordings.
Awesome.
Yeah, so, and then too, I can see what resources I can kind of pull together in regards to emotional labeling with like 5-6-year-olds.
Thank you. That would be really appreciated. And I'll share that with the like Child Care Network because they're the ones that have kind of brought it up a couple of different times about the negative self-talk in those young kiddos.
Yeah. All right.
What other questions or comments do people have? I know that people are probably just sitting there on edge, wanting to ask questions. So I'll be quiet.
No worries if you don't have any. But this is good to know for next time, you know, provide more space. I did like how interactive this was, though, just in terms of in real time, people kind of interjecting with reflections or questions.
If people have questions or comments after, please feel free to reach out. I'll make sure that Emily and Autumn's email is included in the email I send out with the certificate and the presentation and all of that. I recorded the presentation today, so we'll be sure to get that on our YouTube station so you can access it. And if there's anything else, resources that are needed, please, please, please reach out. I really enjoyed this time together today.
Thank you, everyone.
Yes.